Having earlier stated that there are 3 phases, I will go ahead to start with the first phase of a given mass campaign. That is the planning and preparations phase. This would entail first an analysis of the situation to be addressed. One should assess the disease burden or epidemiology of a given area that is to be addressed, and routine or essential vaccination, that is the day-to-day vaccination coverage in a given area or in a given population. In addition, identify particularly the high-risk populations and areas with the low vaccination rates. In a non-selective campaign, such problem areas should receive more attention, more resources, given that these are the areas that will contribute to what we call success of the campaign, which is raising the overall population immunity to interrupt disease transmission. In addition, one should try to review and analyze information from any previous campaigns to learn from the successes and the challenges. The best practices should be applied, while the same challenges which were seen in the previous campaigns are likely to recur and should hence be mitigated in this future campaign. The next element is to define the campaign objective. As I stated previously, the next element is to clearly state the goals and target age of a given campaign, whether it is geographical as well as the coverage and which might mandate further action. Examples: you could say that this is going to be a nationwide campaign or a campaign in designated provinces for under 5 measles vaccination, where coverage expected is 90-95% above as success. Or it could be in the HPV or human papillomavirus vaccine, that all girls 9 to 14 years catch up at the introduction of the HPV vaccine in the country for the control of the cancer of the mouth of the uterus or the cervix. Alternatively, it could be all recruits to a nursing school or to the military as part of prevention of outbreaks, when such people from across the country suddenly gather and with the potential for disease outbreaks, especially like measles or meningitis. As I said earlier, what the campaign is set to achieve or objective and the definition of success should be clear and understood by all actors, so that everybody is working towards achieving that objective. The next element is to develop a broad plan or a guiding plan. At the start, campaign managers should create a broad guiding plan of broadly how will this work, and based on the target goals and objectives. This initial broad plan should estimate the overall financial and human resource requirements, as well as key material inputs like vaccine doses, campaign logistics, like maybe injection equipment, cold chain, and a clear managerial timeline, or sometimes which is called a Gantt chart. I have seen timelines spread over 3 to 5 pages. Such are not useful as a managerial overview. In my opinion, a campaign timeline for each level of the campaign should be a single 1-page landscape visual, as I illustrate here. This overall plan is essential for meeting with the policy makers and the budget authorities. It is also necessary as guidance to the lower level administrative units. The next element I would like to cover here is how to secure the necessary campaign funding and other resources. Here, there are three self-explanatory elements. 1. Mobilize financial resources from government, from partners, private sectors, and other contributions. 2. Ensure availability of key campaign supplies, that is, enough vaccine doses, self-injection equipment, the cold chain, because vaccines generally need to be kept in a cold environment if they are to be viable up to the time of administration. So one should secure essential supplies in order to satisfy a sudden spike in needs, because campaigns in a short time, you might need millions of doses. That will mean more equipment in a short time. Finally, one should identify all the requisite human resources, including trained supervisors, health workers, volunteers, as well as community mobilizers, which human resource package will be necessary for success. We go on to the next stage, or the next element of campaign success. That is, to send out trained campaign supervisors to assist the lower level administrative units in developing micro plans. In many campaigns, you will hear about the word micro plans. And in my opinion, micro plans and micro planning is probably the most misunderstood terminology and practice in running mass campaigns. Microplanning is the identification of which target, e.g. children or particular group, as we discussed previously, if it's not just children, are to be vaccinated by which teams and over what time. This is an example of a microplan, as I illustrate. In it, we see a definition of the team, the number of children or the target to be covered, where, and by inference, that the workload or the degree of ease or difficulty in actually vaccinating or reaching that target. Based on the lower level microplans, the next higher level campaign management should develop detailed aggregate operational plans, which include 1. Logistics, the timeline for achieving the various preparatory activities, the definition of the vaccination sites, and the outreach strategies which will ensure, for example, fixed outreach or mobile teams in order to ensure that everybody who is a target is actually reached and vaccinated. Another element is to address the cold chain adequacy. Any additions of more cold chain temporarily or arrangements to ensure new procurement of cold chain to assure that the vaccines that reach the grassroots are safe and efficacious. After this, we should use the aggregation of the microplans to advise the initial broad plan which was developed to have actual accurate operational plan for how the campaign will run. Therefore, contrary to what you may hear, there can never be a provincial or national microplans. The national or provincial plans can only be aggregations of the lower level microplans. The next element in this planning and preparations is to identify and engage key stakeholders to bring extra efforts and support other than just the health sector. Campaign managers should actively engage with other government agencies. For example, it could be the education sector, military for logistics or security, NGOs which are operating in the area, the private sector which operates in the area, for either financial contribution, but more usually in-kind contribution to augment the health sector activities towards success. Campaign managers should remember that resources alone are not enough to ensure campaign success. Successful campaigns actively involve the communities to build trust and ensure participation. For this, the campaign manager must get community and religious leaders as well as key influencers on your side. Here there's a very interesting example. Elvis Presley, who took the polio vaccine publicly, used his social influence to normalize getting the polio vaccine, which increased vaccination rates among American youth to over 80% in just 6 months in America. Similarly, in the Muslim world, for example, during the polio campaigns, they appealed to the Al-Azhar Muslim scholars in the Middle East, in the Muslim countries, in order to improve vaccine uptake. On the other hand, in the pandemic of 2009 in Europe, some European countries placed vaccines in pharmacies with the assumption that everybody visits the pharmacy and everybody will go and get the vaccines there. But those authorities forgot to involve the family clinicians, many of whom confessed ignorance about the immunization campaign, with subsequent poor uptake and millions of doses laid to waste because they were not utilized. The next element I need to cover here is communication and social mobilization. A successful campaign will have to understand and probably study the target audience in order to develop culturally appropriate messaging to promote vaccine uptake and to address any vaccine hesitancy. Vaccine hesitancy is a major topic by itself, and I would like to refer to other aspects of addressing vaccine hesitancy in large populations. But as an example, in 1796, Edward Jenner, who championed the vaccination against smallpox using cowpox materials, the population came out saying that they should not take the vaccine because at that time, vaccination would turn the people into cows. Clearly, we did not see people turning into cows. Campaign managers should be ready to accept that they may be out of their depth and reaching out to comms professionals in the use of multiple channels, either radio, TV, social media, community meetings, town criers, or word of mouth in order to raise community awareness and acceptance of vaccinations. In addition, a good campaign should equip health workers to address concerns. Most vaccine hesitancy is actually community-based on some concerns, real or imagined or rumors. Particularly increasing in the current times of the internet and social media, health workers and campaign managers must be willing to face and question and to be equipped and ready to provide accurate information to alleviate community concerns and hesitancy. After here, I would like to cover the other aspect which naturally follows, that is to identify where and build in where the campaign can strengthen routine immunization. Mass campaigns involve a lot of time and resources, both human and financial, in order to be successful. So this amount of resources devoted to mass campaigns should provide opportunities to enhance routine immunization systems towards long-term improvements in outreach to the underserved communities, as well as program monitoring. Many campaign managers make the mistake of believing that strengthening essential or routine immunization will automatically occur by default. We have seen with experience that unfortunately, in most cases, this is not true. Managers at each level should specifically and in advance identify 1 to 3, not more, key weaknesses in the health systems which should be targeted for strengthening by SIS or mass campaigns, and to deliberately make an effort to invest in and sustain such strengthening where the campaign efforts and resources actually support the regular, routine, ongoing immunization activities. This could be with training, outreach supervision, investment in new cold chain, or better mapping and estimation of the catchment populations, or getting political leaders and engaging them in mobilization of their communities to uptake of vaccines. The important point here is to sustain such campaign-based practices after the campaign is over.